already recording.
اوكي تمام يا دكتور، شكرا.
تمام. اوكي، كده اوكي. انتوا سامعين والسكرين باينه؟
كله تمام.
Okay, perfect. Uh, as we said earlier, the effect of the burn, the patient or the whoever is exposed to the burn will take it with him till his grave, because it will definitely leave a mark on his body and definitely on his psyche. Perhaps what people don't understand about burns is that it is something that can tax any expenses and can have a dire effect on any economy, even in the most developed countries, because a burn patient or care of a burn patient or having a proper burn unit is a very expensive uh, undertaking. And also, if the patient is self-paying, then you cannot imagine how much it can cost and for how long it will cost. And there are patients who have undergone more than 10, 20, and even more surgeries. And of course, the ultimate dream is to have no effect or no memories of his burn, something that is next to impossible. That's why the impact of burn on economy of a nation or on a personal economy is something that's very, 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 very hard to need to estimate, and something that is very miserable, especially for the patient. He will never ever be the same again, even in the best hands, wherever in the world. There will always be some memory of his burn. With this as a starter, we have to know what is burn. A burn is a coagulative necrosis of the surface layer of the skin. And for us to understand what is a coagulative necrosis and what happens in the skin, then we have to know what is the skin. Skin is the largest organ in the body. It is responsible for multiple functions, perhaps the simplest of which is protection of the underlying structure. The skin is the most sensitive area. It conveys all the sensations to the interior of the body. It's rich in nerve endings. Some areas are richer than others, especially the face, tips of the hands. But it conveys anything from the external environment to the body to interpret. You interpret pain, you interpret touch, you interpret heat, you interpret cold. It's responsible for all the sensations that are conveyed to the human body. Then it's responsible for protection against any external invaders, by virtue of its mechanical part and by virtue of the secretions that are coming out of it. And of course, we have to know that it is the most important factor in regulating the body temperature. This happens through its control of the sweat secretion that compensates for excessive heat produced in the body, and by vasoconstriction that happens in the skin that shuts down this production of sweat in cases of cold weather. And another very important function is production of the vitamin D. Especially we've been speaking a lot about the value of the skin of the vitamin D in the body, and that's one important structure, important vitamin for everything that happens inside the body. But anyways, it's regulated by skin through exposure to the sunlight. And of course, we can never deny the effect of the vitamin D on the human body, but it's not the scope of our talk today. Uh, if we speak histologically, the skin is composed of two main layers, and the third layer, the subcutaneous tissue. But if we're talking about the skin itself, it has the epidermis and the dermis. The epidermis is divided into another three layers. The very superficial layer, this is histology, this is old school, but I think you all know it by now. But just for you to know, if we're talking about the skin, the outer layer or the horny layer, this is non-viable cells. It differs in thickness from one layer to the other, from one area of the skin of the human body to the other. But anyway, this is non-viable cells. And with another layer at its lower part, the granular layer or the stratified squamous epithelium. If you remember it from this histology lessons, it's responsible for producing this keratinized dead layers that are above it. And then you have the basal layer of it, or the foramen stratum granulosum. This is responsible for the degeneration, and it carries with it most of the nerve endings. Then we go to the dermal layer, which is the regenerative layer of the skin. This has the vessels, the roots of the sweat glands, the hair follicles, and it is responsible for the regeneration of the skin. If we speak about the skin, then we have to know that this major function that's involved in our talk today about burns is the value of the skin in adjusting the fluid and electrolyte requirements or homeostasis of the human body. If we know that two-thirds of the human body is water, and that most of this water is present in the intercellular compartment inside the cells, and the only one-third of it is present in the interstitial fluid between the cells and in the circulation. With the skin function, it is very important to adjust the balance between the fluid intake and the fluid output, or what's excreted through the skin or through the human body, either in urine, sweat, which are the major things, or other if fluids just got out with the stools. This is minor, but anyway, the major thing is major excretions through the skin and the sweat and the urine. And the intake, of course, is the internal water that you drink, or the food that's responsible for a minimal part of it, or products of the metabolism inside the body. We have to make sure with a daily intake that you have 1 milligram per kilogram per hour. This is the daily requirement that you have. They cannot, if you take less than that, then you expose yourself to the hazards of having. No, we cannot say that we go to straight dehydration, but still, this is not the right way to go if you reduce your daily input less than 1 milligram per kilogram per hour. This will transfer. Ultimately, if you do all go on with your mathematics and calculations, you find out that you're drinking around 60 cc's an hour, multiplied by 24, then this is what you need per day of water. This is balanced also by what you gets out of your body. The average urinary output is around 800 to 1 liter, and then insensible loss through the sweat and perspiration, you get out the rest of this 1.5 liters. So the balance is that you're always in equilibrium between your water intake and your water output. This keeps everything in check. Your cardiac output is okay, your renal output is okay, you wash out the excess metabolites that are present in your body, and this is all very important to understand later what happens in a burn. Because with this understanding, with knowing the functions of the skin, we know what are the disturbances that are going to happen in a case of a burn. The causes of burn vary very simply from a very broad spectrum. The body can tolerate, just if you stay in the sun, going in the beach or wherever, you can stay in temperatures up to 40 degrees centigrade for quite some time, even hours. But if this exposure gets more than that, you always felt it, that your burning sensation, the scalds that happen, the blisters, the bully. So a burn is exposure of the body to a temperature that's above its normal tolerance, which is a maximum of 40 degrees for a limited period of time, minutes or no maximum an hour. Other than that, then you're exposing your skin to a certain level of heat that it cannot stand, and it will react to it with burns. The types of burns, the commonest and the most that you see every day are the scalds, which is hot water, maybe from a boiling pan, from the shower, from wherever. The scalds are the commonest household thing. You see them every day. You see them different age groups. Mostly you see it in children because children are vulnerable and they mess a lot. Then comes the flash burns, which is heat that's coming from maybe the commonest or maybe the funniest, and of course the most serious is lightning. It's a flash burn. It can hit, although the effect of this lightning is not as drastic as you see the burn, but it will alter all the internal environment and it can even be lethal, can lead to cardiac arrest. Other burns, special burns, are the electric burns. We'll talk about them. The chemical burns, acids, alkalis, whatever, and the ionizing irradiation that's we see. If you the commonest, of course, or the mostly in the medical practice, when you see patients exposing to the radiotherapy and you see what the effect of this radiation has on their skin, it causes burns. Now, to emphasize the most serious of them, the scalds are simple, as we said, that the most serious is the electric burn. The electric burn trouble with it is that its energy flows through your body, and the extent of damage is unpredictable because there are areas of your body that are very good conductors of electricity. It goes through them, and it can go to a distant part as though the inlet of the current or the electricity that hit you, maybe he catches it with his hand, and then you find out that the damage is extensive through the whole limb because the vessels, the muscles, and the nerves are very good conductors of electricity. The exact opposite is the bone. It's a poor conductor of electricity, but this has even more damage because it tends to store the heat and dissipate it to the areas around it, causing extensive damage. So electric burns are the most serious and the most challenging for the managing doctor because he has to be aware of the extent of the damage in spite of the fact that apparently the inlet of the current and the exit of the current are apparently they look very innocent, but all the area between them can be extensively damaged through the electricity that flowed through the muscles, the vessels, and the nerves, and the heat that's been developed in the bones. Uh, Another serious thing is the inhalation injury. You can be exposed to uh, smoke, or high temperature, or vapor. This you inhale this. The damage is unseen. It's not apparent on the surface, but this is very serious because edema that happens in the throat, for example, this can cause choking. Patient, you can lose your patient, and this patient, he needs an emergency intubation. You have to be very cautious if this patient has been exposed to a lot of smoke, then or has been exposed to a vapor, hot fumes. You have to bear it in mind always that inhalation injury is a serious injury and it has an impact on anything that you're going to do in your management later. So you have to be cautious. You can diagnose it by patient coughing carbonaceous sputum, dark colored. He is having difficulty in breathing or choking, or if he has anything related, um, of that makes you suspicious that his breathing is not okay, he is an indication for immediate admission to the hospital and care. And even you exceed, you have to manage with the fluid requirements that he's going to take. You're going to add more because of this uh, inhalation injury. Another injury that's, excuse me, I think I skipped this, which is the chemical injury. Chemical injury, okay. Before we speak about the effects, we have to say a word about the chemical injuries. Chemical injuries, they look innocent, but they are serious because their extent of damage can be much more than what they are look like. Simply, the simplest thing is the bleaching agents that are present in every household, and some people drink them. They burn out their esophagus. You see that a lot. This can affect the skin. It's always the girlfriend boyfriend affair. They leave each other, so what they have, they throw the acids on them. It's perhaps mayatonor or the sulfuric acid that's poured on a lot of faces, and it has deleterious damage. Usually the damage is much more extensive than what it apparently is. So it's it's worth considering that chemical burns are serious burns. You need immediate management. You need to know what is the agent, and you have to emphasize this very clearly when you're managing a case of a chemical burn. Now, if we proceed to the effects of the burn, effect of the burn, first thing to know is that the burn happens in a second, but the effect of it goes on for a long period of time. So what happens is that, technically speaking, the body tends to store the heat. The cells, by nature, by default, they tend to store heat. So long as they're storing heat, the effect of the burn is proceeding on and on and on. The effect of the burn can be at the site which came in touch with the burn, and the region around it, and distant effects. So locally, you have damage, direct necrosis from the extensive damage that happened to the cell membrane at the region of the burn itself, which came in touch with the burn, whether be it heat, scald, electricity, chemical. The direct damage causes extensive necrosis to the area, and the vessels in it, the vessels in the area, the capillaries surrounding the area of the burn or at the area of the burn, you find out that their walls are disrupted. The cell membranes of their cell membranes are damaged. So this explains to you what happens, because they tend to leak water, leak fluid from them. And this is very important when you know the management in the area where the damage of the burn except happened. Uh, Locally, you can also know what's going to happen from the understanding of the depth of the burn. We're going to talk about this later, but for the time being, we have to know that the area exactly of the burn itself, you find out a severe leak of fluid because of the capillary damage. You find out a severe inflammatory reaction because of the release of inflammatory mediators from the damaged capillaries. And this is the area that's most prone to infection later, because this is the area where the extensive damage happened. In the regional area around it, you find out the edema. This may be extensive, especially we're talking about the edema that's developed in the muscles in a certain compartment, which I think you all know about the compartmental syndromes. This is very important in the limbs, in the periphery, where you can find out that due to the edema, the muscles are compressed inside a certain compartment, being the extensor compartment, flexor compartment, whatever. Subfascial edema lead to muscle necrosis, and the damage can be very extensive to the tissues because of this edema that developed in the tissues. Uh, the, this is also one of the major effects from the dehydration. You can find that there's venous stasis and venous thrombosis, and this can have also a deleterious effect later on. It leads to uh, extensive swelling, and it will add to the compartmental syndromes, and this can even be more serious. Perhaps what is always missed is the systemic effect of a burn. If we're talking about a burn that involves more than 10 to 15% of the body surface area, we start to think about major burns, about they exceed 15% in adults, or less than even 10, or some people say 5% in infants or young or children. The systemic effect is worth considering, because this has the major burn front on your management later. The most important is that its effect on the cardiovascular system. As we said earlier, when the zone of injury or locally, there is extensive loss of fluids from the capillaries that have been damaged in the area that was exposed to the burn. This would definitely lead to a drop in the cardiac output. Perfusion to the vital organs is affected. Find that the patient will have markedly tachycardic, his blood pressure will drop, and all the vital functions. You can find patients, it's very common, patients with burn, and find out they're not, we cannot say that proceed to coma, this is serious, but at least they find out that are confused because their cerebral perfusion is not at its best. So this effect can go on for up to 8 to 12 hours, which will have an emphasis on what we're going to say later on the management and the fluid replacement, because this is maximal at the first 8 to 12 hours. After that, the effect of the venous thrombosis, if you're not correcting properly the fluid requirements, so the hemoconcentration happens, and then you find out that the patient is maybe at the risk of having venous or even arterial thrombosis. If the compartmental syndrome, inflammatory mediators, uh, they can have a deleterious effect. That the release of the catecholamines will lead to peripheral vasoconstriction, which will even add to the drop in the cardiac output. So it's very important to know what are the cardiovascular effects of burns, so that we know in our management or our monitoring of the progress of a patient, the cardiac output, if his pulse rate is getting lower, then this is a good sign he's properly perfused and he's resuming his homeostasis again. Or if not, then we have to correct and look again and recorrect and readjust our fluid requirements and management of the burned patient. One very important uh, system is the genitourinary system, because if in the case of a burn, there's the muscle. If the muscle there's extensive muscle damage, there's release of inflammatory mediators. It can lead to the drop in the urinary output, and if it's less than zero point 0.5 to 1 cc per hour, then per kilogram per minute, then we have a serious issue, because we have to make sure that the patient at least passes 50 cc's of urine per hour to ensure a proper renal function. If muscle is damaged and there's release of myoglobin, and if this is precipitated in the glomerular filtrate, it will affect it drastically, leading to oliguria, which is a very bad sign. It has to be corrected immediately by increasing the water out, the fluid intake to the patient, so that we adjust this and maintain the renal function, the renal perfusion. If we look at the GIT, it's affected directly. If we all know about the stress ulcers that can happen in the stomach from the effect of the burn, from the stress that the patient is exposed to, and it can lead to hematemesis, which can be even life-threatening at one point. If we look at the immune system, patient's immunity drops drastically in cases of burns. This we have to be, it has a direct emphasis on how we are going to manage him later, giving him a proper antibiotic cover, but taking care of protecting him against any nosocomial or any other infection that can happen to him, because his immune system is affected directly from the release of the inflammatory mediator and from a direct effect of the burn and the whole stress that the patient is exposed to. It directly affects his immune system. If we talk about the central nervous system, it's very important to know that burn, whether short term or long term, as we said earlier, short term the cerebral perfusion can be affected, but long term, all patients with burn need to be under psychological assessment and direct psychological supervision from a professional psychologist or psychiatrist, to make sure that he can tide him over the strange period of time, or the very hard period that he is going to live with for a and prepare him for that he has to live with the damage that happened to him for as long as it takes. It's very important to know the effect of burns on the whole body, so that we appreciate exactly what we're going and our plan of management, what are we going to do to this patient. Because understanding this makes it easier for us to understand how we're going to manage him. This is another just slide to show you where the effects on every part of the human body. And then we go to the extent to assess and to emphasize how to know or how to diagnose the burn and its effect. Uh, Burns, traditionally or classically speaking, they're classified into 3 degrees: superficial or first degree burns, partial thickness burns, and full thickness burns. This is related, or this classification takes into consideration what happens in the skin, it's the layers of the skin itself. As we said earlier, the skin, we have the superficial or epidermis and the dermis, and then the subcutaneous tissue or underlying structures that the skin was supposed to protect. If the damage is in the superficial epidermal layer, then it's a first degree burn. If it involves the deeper layer of the skin, the regenerative area of the skin, then it's partial degree burn. And then if it involves the full thickness of the skin or the underlying structure, then there's the third degree burn. And some people say that if it involves the vessels and nerves and muscles, then they even give it a fourth degree burn. They call it a fourth degree. But how can we differentiate a first degree burn from a second degree burn from a third degree burn? First degree burn, that perhaps the easiest way to describe it is the one that the sunburn that you're exposed to, or the fluid, just uh, hot fluid comes into contact with your skin. Just this is hyperemia in the skin. You find out in 1 or 2 days, the skin peels off to leave underlying it perfectly healed skin. It's very painful because this is the richest area of nerve endings. But the good part is that it heals without consequences. Second degree burn has 2 degrees, 2 grades. Some people call it the superficial partial thickness or deep partial thickness or deep second degree burn. This is divided according to the degree of involvement of the dermal layer. If it's only the superficial dermis, then you still they are painful, but and you find the blister, that bully that happens in the skin, and then if it continues as superficial second degree, it will go on and heal within a week or 10 days without consequences. The second part of it, or the deep dermal or deep partial thickness or deep second degree burn, is the one that has deep involvement of the dermal layers with damage, extensive damage to the sweat glands, sebaceous glands, where regeneration is usually by fibrosis and contracture. Some people say that the deep second degree can go into being a third degree, where there's complete damage of all the skin layers and the adnexal tissues of the skin, leading to extensive fibrosis and damage and and healing by fibrous tissue and contraction and the deformities that we usually see in the skin. This is a demonstration. This is the first degree burn. It's clear. It's peeling of the skin, leaving under perfectly healed skin. This is a superficial second degree burn. You find out that these bully, if you just peel them off, you find out that the skin is the appendages of the skin are apparent in the early second degree, but in a deeper one, you'll find out that the underlying structures, the skin is totally damaged, exposing the deeper layers of the skin or even the subcutaneous tissue. With the third degree, the skin is completely, you feel painless. You don't feel any pain. Although the pressure can sometimes the patients can feel it, but we usually describe it classically that this in the third degree burn, all the skin appendages are damaged, so you don't feel pain. But the skin looks like it's leather, a piece of leather like this, and this is the deepest layer. The deepest layers of the skin are involved, and sometimes the underlying structures are also involved. This is the skin. This is one type of burn that's deceiving, because the patient apparently will not be in pain, but although he's not in pain, he has the most serious and most extensive damage that one can imagine, and this needs immediate management, or management with a different concept than simply dressing him and that's it. That's another demonstration to show you what I mean by first, second, and three. And I think in one point in everybody's life has been exposed to the 3 degrees, at least the first or the second. Maybe the third, I wish nobody ever sees it. But if we're talking about the first and second degrees, you meet them in your everyday life. First degree, you usually see it at home, scalds, carrying a hot pan or whatever. With the second degree, same thing. You hold the pan, but if it's hotter than what you usually expect or accept. And the third degree, God forbid, I don't want anybody to see it. But anyway, this is an extensive burn that's not in the regular household community. So you don't meet it in everyday life, but you can meet it, of course, in extensive accidents, car wrecks, burns in factories or whatever. This is something that we don't like to see in everyday life. Now, after we know or we look or understand what's happening in the burn as the regards the depth damage to the underlying to the skin and the underlying adnexa, we need to know what is the extent of this burn, because this has a direct emphasis, as we said earlier, that the skin at the zone of the injury, it loses fluid. So the wider the extent of the burn, then the more that we expect of fluid loss and damage to the systemic, the whole the systems of the body, like we said, the cardiovascular, the genitourinary, the GIT. This is mostly happening due to the extent of the burn. The more the extent of the burn, the more the damage to the underlying structure, because there's more fluid loss, there's more chance of getting infection. So this has to be very accurately calculated and thoroughly analyzed so that we know what are we going to do to our patient. The simplest formula, and the formula that, as they say, this stood the test of time, is the rule of nine, where they give 9% for every limb. The upper limb, one limb is 9, the other limb is another 9. For every lower limb, it's 18. And for the torso is another 18. For the back, 18. For the head and neck, it's 18. And for perineum is 1. This makes it 100. The problem with this kind of formula is that it's not very accurate, because it disregards minor damage. Because the way they say it, if there's a minor damage even in the forearm, it's calculated as 9, because they say we disregard it, we just see this a rule of 9. There's anything in the lower limb, then it's another 18. So it tends to overestimate the degree of burn. This is not exactly what you want to see, because if you find out that by the simple calculations of the rule of 9, the patient has even 40 or 50-degree burn, when in real world it's no more than 25 or 30. If you calculate it in a in a more accurate way. So the rule of 9 now gave way, not everywhere, but if you will happen to be a burn specialist, then you will not follow the rule of 9. And there's another rule stating dividing the body into forearm, arm, thighs, legs, abdomen, chest, and giving every part of this its uh, proper percentage, starting from 1.5 to 3.5. So if you calculate it, it ends up something like the 9. It's the 9 also, but it's divided into minor parts so that you can easily calculate the damage. If it's in the forearm, then it's 2.5. If it's in the arm, another 2.5. And if it's the hand itself, it's another 1.5. So if you calculate it, they find out that you're getting into the 9, but in a more accurate, a more sophisticated way. And this is exactly what you need if you want to have a proper calculation or proper estimate of the degree of burn, because this is going to say how you're going to manage this burn. Now, burn management is very challenging, because it starts immediately once the accident happens. You have things that you have to do straight away. If you are encountered with any patient with any degree of burn or any burn, there are things that you have to do immediately. Immediately means taking the patient away from the area of the burn. If he puts his hand by any means in any kind of electricity, just switch off the electricity or take him away from it. If he's holding something hot, fluid or something, just take him away from it. If his clothes are burned with any damage, just take him away. Cover him with a blanket so that you just stop this burn from continuing the damage that it's doing immediately. If you can cool his body with any cold water, ice, whatever cold material that you have, you should pour on him so that he cool the body, because as we said earlier, the effect of the burn is not from the direct contact, it's due to the latent heat that's deposited in the tissues. So what you should do or emphasize is that you have to cool these tissues. The first aid management entails taking him away or removing him as far as possible from the cause of the burn, from the agent that caused the burn, cooling his body as soon as you can. Cold water will do for 5 minutes, 10 minutes, and then you can repeat this. Of course, by this time, you can transfer him to a burn center with definitive management will be, but if not, then at least every half hour, you should cool him again with 5 minutes of cold water or ice as much as you can. Wrap him in something in a blanket or clothes so that you stop the burning, whatever clothes that he has, they are burned. And then you should start immediately that if you see that it's an extensive burn, immediately transfer him to the burn center. In a burn center, then, or at least first aid, let's divide it more accurate into a first aid or an emergency department. In an emergency department, you have a few things that you have to do even if you're not specialized in burns. Perhaps the most important thing is to secure a venous line. Make sure that he has a patent airway, the ABCDE of any first aid management. Ensure a patent airway, like we said earlier. Inhalation injury, a patient can go into total respiratory failure or he's choking if you just spotted it earlier, and you can put a patient tucking into the tracheal tube once you see the patient in the emergency department. This can be a lifesaver. The breathing, the airway, a venous line, secure a wide bore cannula, fix a urinary catheter, make sure measure his pulse rate, and then as much as possible take away the insulting agent. If it's his clothes, take off his clothes, put other clothes. If it is acid or alkali that's been poured on him, then the best way to treat it is copious dilution with water. And then you have to make sure that patient is give him something for his pain, because if it is a first or second degree pain, this pain can lead to shock for him. So it's very important to make sure of these emergency things that you have to do once you see a first aid burn patient coming to your service at the emergency department. Airway, breathing, circulation, uh, direct injury, and look at around the other system involved, because sometimes patients can be having other injuries. Maybe he fell over, maybe it was a car accident with the burn. There are other injuries. So you have to make sure for the first look, the airway is patent. In a burn patient, you have to watch out if there's any risk of inhalation injury. So you have to tuck an endotracheal tube, make sure that he has a patent airway, a wide bore cannula, and of course, if you can, in the first aid measures, fix him a urinary catheter to be able to monitor whatever fluid you're giving him. And then once you have this in place, you can start asking what happened. Patient came to you, what was the nature of the burn? What happened exactly? Was it fluid? Was it alkali? Was it acid? Was it electricity? Was it a flame scald? Whatever, flash injury, whatever happened. This is the second step that you should think about. But just first, do the emergent things, because these are the life savers. This is very important. Then you look at the burn. After you make sure that you did all this, then comes the look at the burn. If you find out there's emergency escaratomes, as we said earlier, that the burn leads to edema and swelling. If you find out that the circulation in the extremities, upper limb or lower limb, hands, feet, arm, forearm, find that it's swollen out of proportion and there's limitation of movement, then an immediate escaratomy. What's meant by escaratomy is you incise the skin. And you find out, strangely enough, don't panic, but if you find out that when you're incising the skin along the compartment, let's say the forearm on the dorsal, the hand on the dorsal surface, or the digits along the radial aspects, or the radial aspects in the lateral 3.5 fingers, and on the medial aspect on the medial 1.5 fingers on the under aspect, or the forearm in the axial plane. Just make sure that you incise all the compartments that you think are compressed directly. this is a lifesaver. If you find out that in his chest that the patient cannot breathe easily because there's tight compression on his head, do a lateral escalation along the flanks. Do it immediately. This is a lifesaver. And you know that you did up something proper because by saying that once you do the incision, you find that the wound as though it's gaping very widely. That's because of the relief of edema that happened once you incised your skin. The skin edges go very far from each other. Don't panic, don't worry. Once this patient is corrected, this is going to go back again to where it was, and you find that this extensive wound that you saw will heal in a matter of a week or 10 days to even a linear scar. But this is what you should do immediately once you see the patient. See, as I said earlier, water, blankets, inhalation, make sure that you have a patent airway. If under any conditions you find a patient, let's say a star or asphalt came to his face or to his body or wherever it is, don't try to wash it out in the street or on the. Take him to the burn center. Take him under anesthesia because this could be painful, and this could be you could be adding more damage if you try to scrub it forcefully in the scene or in the emergency department. You have to take him to the OT and do that. But it's important that you take care and you know what happened to the patient, so that you know exactly what your further plan of management. Now, once you got the medical history, if there has any other problems, if there's any other trauma to other parts of the body, fractures, internal injuries, uh, once this is done, then you have to proceed to the what's more important, how you're going to manage your patient. As we said, escarotomy, this is a lifesaver because if you just wait or you just don't spot it immediately that there's limitation of movement or extensive edema out of proportion to the regular that's acceptable, then you have to do it immediately because if patient goes through compartment syndrome, then you're taking the risk of having necrosis of this muscle, release of myoglobins, renal affection, you can lead renal failure. All this is something that's avoidable if you have a proper understanding of what can happen in a burn and what you need to do immediately before even starting your management plan for resuscitation of this patient. Now, as we said earlier, with a burn, there is capillary damage and there is release of fluids. So the patient tends to lose a lot of fluid through the burn surface. So you have to resuscitate this or correct it quickly so that you don't, the patient is not exposed to any cardiovascular manifestations or renal affection. As we said earlier also, that most of the damage that happens is in the early 8 to 12 hours. So what we do is we have a formula that says, the Parkland formula, very famous, it stood the test of time also. It's you apply 4 cc, 4 multiplied by the extent of the damage, of the surface area damage, which is, as we said, either you apply, for drop the rule of 9 now, as we said, we apply the degree of burn and multiply by the body weight. Once you have this number, you give half of it in the first 8 hours because you need to do a quick correction. As we said, the extent of the capillary, extensive capillary permeability and insensible loss through the burn area is maximum in the first 12 hours. So you have to give half of this fluid in the first 8 hours. And then the rest of it is in the remaining 16 hours. So what is the kind of fluid that you're going to give? You give the most physiological fluid acceptable, which is the lactated ringers. Provided the patient has no liver affection, that's where your history comes in. If the patient has any kind of hepatic affection, then you have to change from the lactated ringers because the lactates will predispose him to to hepatic precoma or coma. So just drop it. The body cannot metabolize the lactates, so you can shift to the normal saline. Putting into consideration that if the patient, or if you're suspecting that the patient has inhalation injury, This is something that you should add to the fluid requisites. Some people claim that you can add up to 40% more from what you calculated if you're suspecting inhalational injury, because inhalational injury is something that you need to correct as soon as you can because it can have lethal effects on your patient. So once you made your adjustments and you made your calculations, what's your monitor? Your monitor is the urinary output. This is the only thing that you can see. If the patient brings out a good urine out of one, as we said, 1 milliliter per kilogram per hour, or 1.5 to 2 in children, then you are on the proper track, and the patient is, you can tide him over the emergency of the first few hours with no risk of affection of the cardiovascular system or the renal system, which is your most challenging part in the early phase of management of a burn. Uh, After you did that, you put the cannula, you started your fluids. Patient is managed by no other injuries. You're sure the patient is stabilized. You change his clothes. You put him in proper sterile dressings. Then you should look now at your wound, which is what you should be doing either better in a specialized burn center where they can have a proper assessment of the wound. They tell you if it's first, second, or degree or third degree patient burn, where you need different kind of management for every one of them. As we said earlier, that we did the assessment, we did the early management, then we have to direct our attention to the burn itself and see what we can do to the uh, burn. This is another simple example of a patient to show you how we can calculate it. It's just like if we say the 50% patient, 50-year-old patient with 50% burn, if you multiply it, then you have 10,000 mLs. You give the first 5 liters in the early 8 hours, and then the other 5 liters in the next 16 hours at the rate of, it will be, if you divide it, then you'll find out that it is around 350 mLs per hour. Anyway, what's important is that you have a clear understanding of the value of what you're doing, especially in the first 8 to 12 hours, and having a patient with a urinary catheter so that you understand exactly what's happening now when you're uh, replacing or replenishing his fluids from what he lost from the surface of the burning surface area, to make sure that his cardiovascular and renal systems are functioning properly. This is very important. Before you proceed to the topical care of the wound, you have to make sure that his vital functions, his homeostasis is maintained. This is what's going to kill him. Immediately, the early cause of death in a patient with a burn is the fluid and electrolyte or the renal shutdown and cardiovascular affection. This is the early cause of death. If you are successful in your early management, then you will not lose your patient from an inadequate resuscitation. And then you're directed towards the management of the burn itself. As we said earlier, burns affects the management of the topical management of the wound is according if it's first degree, second degree, or third degree burn. With first degree burns, topical management will do everything. You just apply. We can go on debating if it's the exposure method or the closure method. With first degree burns, whatever you do, they are going to heal with no consequences. So all you need to do is to protect the skin against the exudation and to provide a proper antibiotic cover to guard against infection from the underlying structures by the exposed skin. Whether you do it by exposure method, it's usually, this is applicable areas like the face, the hands, where bandaging them would be very irritating or very inconvenient to your patient. So what you do is you clean the area, you just puncture the blisters, don't try to remove them. You apply a sterilization fluid like betadine or whichever, and then we're going to talk about the topical agents that you're going to use. Whatever the topical antibiotic that you're going to use or topical agent, the idea of it is to act as a barrier against invading microorganisms, at the same time aiding in the healing. If we go to the uh, occlusive method, which is applicable in, let's say, extensive burns, chest, abdomen, thighs, then some people resort to the occlusive dressing. Technically speaking, you do the same thing, but what happens is that after you apply your antibiotic ointment or whatever dressing agent that you're going to put on the skin, then you apply a thick layer of cotton padding after you apply some after applying gauze or xeroform gauze, what they call, which is impregnated with glycerine or Vaseline so that it does not stick to the skin. Thick layer of cotton padding, and then wrapping of this wound with a crepe bandage, and changing it every 2 to 4 days, or if it gets terribly soaked. Every one of them has its merits. The exposure is that it's patient feel a lot better about it psychologically, that it's not extensive. He can move his hand, his face is not wrapped, he can eat properly, whatever. And then it's in small sized wounds or in minor wounds, then minor burns, this can suffice, and the patient usually heals within a few days. The occlusive dressing has its advantage of protecting against infection because you're covering it anyways. But and if the psychological is still from another point of view, that the patient does not see the extent of the burn that he has or the extent of damage that he has. But everyone has got its merits. uh, like I said, minor burns, face, hands, you go for the exposure method. This is more applicable. In other areas of the body or with extensive burns, then you don't have this luxury, so you go for the occlusive method. Your guidelines in it is not just personal preference, it's just, as I said, where and the extent of the damage. You usually go for if it's a first degree, you can easily go with the exposure, but if it's deeper than a first degree burn, that's not recommended, or it's not exactly the best way to go. You're safer with uh, the occlusive method. Now, as we go, the agents used. The agents in burn that stood the test of science, the silver agents. Silver agents have both an antimicrobial effect, and at the same time they act as a proper barrier, and they say it has an effect on releasing factors that promote healing. Silver components are either silver sulfadiazine. Perhaps if anybody of you is familiar with burns, then they will know the most agents are the flamazine, the dermazine, which is silver sulfadiazine, so you will not forget the names. And there are other silver nitrates. This is a second generation, or different agents like, of course, you commercially, everybody is familiar with the maple, which is something, it's an extract from peanuts. The credit for it goes to the Saudi Arabia. They were the first ones where they realized that the Bedouins there, they used it topically on their skin in cases of burns, and they found dramatic results. So it's been developed commercially. It's not a silver component. If you're confronted, you don't find those maple, you don't find the silver sulfadiazine in any of its carnation, be that whatever commercial name, any antibiotic cover that can cover the spectrum of organisms, gram positives, gram negatives, anaerobes. Of course, you don't see anaerobes at the early phase, but anyway, gram positives and gram negatives, then it is applicable, be it whatever. The idea is to cover the surface of the burn, and at the same time act as a barrier against any external invaders to this exposed skin. These are the consequences of what happens in a first degree burn. You see, it's red in the initial phase. Then you find out as it peels off in 2 or 4 days, you find that the skin underlying it is starting to acquire color instead of the hyperemic appearance that's apparent in the first state. And then later, in a few months' time, you can barely see the effect of the burn. That's not the same about deeper burns. Deeper burns usually they tend to scar because they get fibrous tissue reaction or healing by fibrosis, not by direct epithelialization as it happens in the first degree burn, where from the edges, epithelium creeps and just tides this area. It's still with a sensations preserved and everything. In the second degree burn, what happens is that the effect of the fibroblastic migration, the fibroblasts, they tend to fill this area, and this is what causes the scarring from the extensive impregnation of collagen from the fibroblasts in this area, so that it's unsightly. It's not the natural looking thing. And this is important because it will have an emphasis on what you should be doing in the management of the burns that we're going to talk about in a minute. What you should be doing in the case of a deep second degree or a third degree burn, we'll talk about what you should know is that uh, sometimes it's healthier to excise this area of burn and do an overgraft over it with split skin graft. We're talking about it later, but maybe this will help you to have a better or more decent scar than the extensive scarring that happens if you leave it to heal by itself over a longer period of time. If under any conditions in a second degree burn, you don't have this split skin graft luxury, or you have extensive burn with no donor surface found in the body, so we use either allograft or xenografts. Allografts, as we know, is something that you take from another human. Let's say cadaveric skin that you apply on the burned area. It takes initially, it will act as a proper cover, and then the body will reject it in a matter of a week or two. Usually by maximum of 2 weeks. Yeah, if you stretch it the third week, you find that the body is rejecting it. This is cadaveric skin. It will act as a simple biological cover that can stay for a while and can tide you over the exposure of the skin in this area. If you see that it's a second degree or third degree, as we said earlier, that you excise the burned area and you don't wait for it for coverage to heal by itself to avoid the fibrosis. If you don't find that, then you go for the xenografts, which is cadaveric or amniotic, sorry, not cadaveric, amniotic fluid or bovine, or the synthetic ones, which are in vogue these days. These are artificial materials. The amniotic fluid or the xenografts or the bovine, they usually live for a while and then they are rejected earlier, but they act as a temporary cover to tidy over the initial period of time where there's extensive oozing from the skin and there's extensive fluid loss that you want to get rid of and provide the proper environment for good healing. Now, artificial materials now are becoming in vogue. Sorry, I'll have to go back to this again. Definitely, you all heard about the Integra, you all heard about propane. These are materials that have like a surface or a substrate which provides collagen for healing. So that if you put it on for a while, you can apply a split skin graft over it, so that you have a better looking skin area over the burn area would be better looking than if you leave it to heal by itself. Because after you debride the whole area of the wound or move away the burned area, and then you apply these biological dressings. Of course, we have to put into consideration that this is expensive and not always available. But anyway, if you have it, then good for you. You apply it in a very short while. You can define the epithelium creeping from the edges. And if you just add a split skin graft over it, the take is much better. And the final scarring is much better than if you just apply um, regular dressings and wait for it to heal naturally by extensive fibrosis and scarring. Uh, Now, this is important also for you to know. If you manage, as we said earlier, the patient in the first aid department and the emergency department, and then when you refer him to the burn center. Of course, after you stabilized your patients with inhalation injuries, they have to be admitted uh, to a specialized burn center for further management. Patients with circumferential burns, patients that you already did your escaratomes, you did the good part, then, but further management, it takes a specialized burn center to assess this. And pediatric extremes of age, if we talk about it this way, it's best to put it as extremes of age. If a patient is in younger age, as I said earlier, if it's 5% of the total body area, especially if the face and neck are involved, then it's the indication for admission. Patients who are above 60 years of age with 10%, or yeah, some people stretch it to 15, but anyway, 10%, you have to admit him, especially if he has another comorbidity like it's being a diabetic, ischemic heart, hypertensive patients. You have to put this into consideration. Deeper burns, electric burns are indications for admission to a specialized burn center because this needs extensive management, as I said earlier. Now that we take out the skin, overgraft him, do a lot of further management that has to be done in a specialized uh, area for good management. This is a summation of what we've been talking about earlier, like what you should be doing for a patient with extensive burn or with a burn is immediate rescue, resuscitation, retrieving him to a specialized area, scale management of resuscitation, rehabilitation. This we're going to talk about later, but this is a summation slide just for you. And this is a subject after the burn, the aftermath of burns. I said that in some areas, in some conditions, you need to do it early, like the excision of the burn area and overgrafting it. But sometimes, or if the patient has came to your service, or even if he's in the same admission, you find out that you need to do coverage for this patient, coverage of a burn area, or coverage of a deformity of fibrosis that resulted from this burn, and functional. Maybe the patient has got the burn of the face and he cannot open his mouth, or there's a deformity in his ear, or there's contraction in his neck. He cannot stretch his neck, cannot move his fingers. This is the aftermath, or after the consequences of the burn. It's not say that it's not being properly managed. Some burns are very extensive. Patients are in deleterious conditions, so you direct your attention to saving his life first, and then dealing with these issues at a later stage. Uh, to understand what we're going to do for coverage, then this will lead us to another, and it's what we call the second half of this lecture is about grafts and flaps. What's the difference between a graft and a flap? A graft is an area, is a uh, skin taken away from the body without any blood supply. Just you take it out of the whole body and then you stick it to the burned area. A flap means that you're taking a vascularized piece of skin with underlying subcutaneous tissues, muscles, and even sometimes bones. And you just remove them either on a named blood vessel or on a random pattern or through a microvascular anastomosis where you take this feeding vessel, cut it, and then re-anastomose it to another area of the burn to cover a vital structures that's been exposed or has been damaged by the burn. Uh, Let's start by grafts, the simplest way, and something that you're going to do or you have to know in your practice, even if you're not specialized in burns, they have to know how to make use of a split skin graft or a full thickness skin graft. Split skin grafts means that you're taking the superficial layers of the epidermis or maximum the very superficial dermis. The thickness is around varying from 0.05 from of an inch to 0.018 or 0.02 of an inch. I mean, very thin skin. It's taken out either by a specialized knife or by an electric dermatome, or even with a scalpel if you're talented enough. You can take the famous donor sites are usually the thighs, the buttocks, the back. Or you can take it from any area if you know how to do it, but it's got a technical prerequisites that you stretch the skin so that you take it with the skin without going deeper at any one point. It has the advantage of taking a wide area of skin. You can take as big a piece of skin as you wish. It has the luxury of being meshed. You can put it in a mesher. A mesher is something will increase the surface area of this burn, of this skin that you've taken. Some meshers go 1.5, some meshers go 2, and there are even ones that can go up more than that to cover an extensive area of the burn. What happens when you take a split skin graft? A split skin graft has an underlying surface of elastic tissue that if you just tuck it on the burn area, it's fixed at that time. It acquires its blood supply in the early phases by imbibition, which takes blood supply from the undersurface that's been the exposed undersurface that you properly took out the burn, you took out the burn damaged area, and then you put it on it after proper debridement. Then it will acquire its blood supply the early phase by imbibition from this undersurface. This takes around 2 or 3 days, and then you go through the other phase two of vascularity, which is called the inosculation, where it starts aligning the minute capillaries in the skin that you've taken out with the capillaries in the donor's site. And then third phase of it is the revascularization, where they join and the blood supply starts flowing from the donor surface to the capillaries in the recipient surface or the skin graft knife, of the skin grafted area. It has many advantages, and also everything comes with a penalty or a disadvantage. The advantages are that it can cover a huge area. Technically, it's very easy. The donor site morbidity is very minimal. If you just wait on it for a week or two, and you can take another layer of skin from the same area safely. And it has a big advantage is that it's from the same individual, so it's an autografting. It's you're not taking it from anybody, and the chances of rejection are very minimal. But of course, there are disadvantages. As we said, it acquires its blood supply the early phases from the undersurface by imbibition. So it cannot be applied over bare bone. It cannot be applied over vessels. It cannot be applied over bare cartilage because they don't have a nourishing surface to give them to feed this newcomer or the agent that's been removed from the donor site to its new recipient area. It does not have sensation because this graft is taken through the very superficial layers. You don't have sensations. It's non-sensate, and it's of course it's notorious to be damaged if you apply it. Let's say for a fingertip, it can get burned. It doesn't have sensation to be able to warn the patient or whatever against whatever is happening in the environment around him. Uh, of course, the color match is not perfect because, as we all know, the color of the skin in the thighs or the back or the buttocks, wherever, does not match. For example, the colors match of the face. So the color match is not the good, is very good. And the chances of contracture in it is very high. A point on contracture is, know this golden rule: the thicker, the more elastin, the more contracture. So if you take a split skin graft, thin skin graft, apparently when you take it out, it contracts. So this is what they call the primary contracture. And this is as minimal as it should be or it can be. But as time goes by, it contracts less than, for example, if you take a full thickness graft, which is more elastin, the primary contracture is much less. But the secondary contracture with this one is more extensive because it relies totally on the blood supply, on having new vascularization, and migration of fibroblasts to it is very extensive. If we go from this split skin graft to full thickness grafts, what's meant by full thickness graft is that you take the epidermis and the dermis and you just stop short of the subcutaneous tissue. And the essence of a full thickness graft is removing the fat from the underneath it and applying it still, just the same concept as a full thickness graft on the surface directly. It will acquire its blood supply again by um, imbibition at the early stage, inoculation, and then revascularization later. The advantage of a full thickness graft is that it's the color match is much better because you can take, let's say, if you have something in the face, you can take it from the post auricular area, you can take it from the underarms, you can take it limited areas, but the coverage is not as extensive. You cannot take big sheets as you can do with the split skin graft, but you still have the luxury of being able to take a better color match. Contracture is supposed to be less. Color matching is supposed to be much better. Uh, but anyway, both full thickness and the split thickness, they are non-sensate. With the split thickness graft, the incidence of contracture is high. They cannot be used over exposed bone or periosteum or vessels. And and with the full thickness graft, you have the disadvantage of having a limited supply in the body. Yeah, because you close the site of it directly and it's a wound, so you better put it in a hidden area. This takes us to this phase two. This is a picture of a graft with the coverage of it. What you do is something, this is technical, but most of you will be seeing it. If you do a split skin graft or a full thickness graft, you have to make sure that it's compressed properly against the surface that it's the recipient surface. Because as we said, it would acquire its blood supply by imbibition. So you apply a coverage, a compression coverage on it for 5 or 7 days to make sure that it's sticking properly to the underlying surface. Uh, this has been emphasized earlier when I told you that in a second degree or deep second degree or a third degree burn, you better take off the burned area and either apply the grafts or the, as we said, the alloderm or the synthetic materials, biological dressings that we apply on this area to promote better healing and a better final scar outcome. Uh, This is grafting for the areas. This is the electric dermatome, and this is the thickness of the skin that's supposed to come. Now, this is another subject of interest that most of you will be seeing in the practice, especially in the ER or in the everyday practice for burns. Sometimes you see patients coming to your service with contractures, either in the neck, in the face, the digits, hands, feet. Contracture can happen anywhere. Knee contracture, limitation of movement. So if you try to do release of these scars, then you're deep exposing deep structures or fibrotic structures that cannot be easily covered with a skin graft. So you resort to the important part, which is flaps. Flaps is a very, very, very diverse, broad subject. But in a nutshell, let's say we divide them into either random pattern flaps, axial flaps, pedicle flaps, free flaps, or composite flaps. Quickly, we pass through them. Random pattern flaps is a flap that's not exactly based on a single blood vessel that's supplying it. As we said in a flap earlier, that it's skin, subcutaneous tissue, and muscles underneath, or even bone. All this area is supplied by a known blood vessel. But in a random pattern, you don't rely on on a known blood vessel. So you have to follow certain rules. If you take a random pattern flap, you have to make sure that its width is much less than its length, because the longer it is, the farther it is from the base from you where you took it from, and the higher the chance of losing this flap. And it's got different designs. You'll be definitely hearing about the Z flap, the VY flap, the rhomboid flap. All these are random pattern flap, or the rotational flap, or transposition flap. All these are random pattern flap that you take skin from the neighboring area of the burned area, or the wounded area, or the area that you debrided, and you move them into to cover this exposed area, because it has under vital structures or vessels or exposed bone. And then the donor site, you either close it directly or you apply a split skin graft over it. This because this area it can accept a split skin graft because it's healthy skin that you can apply the skin graft on. This is the random pattern flap. Pedicle flap is that a known vessel that supplies this skin or subcutaneous tissue territory, and you just dissect it, expose the vessel, and rotate this flap or take it to a nearby donor recipient area based on this vessel. In doing so, you're guaranteeing that this vessel, that this area of skin and subcutaneous tissue is well vascularized, so you don't respect the rule that we've been saying earlier that the width should be much more than the length. You don't need to do that because it's simply uh, on an unnamed vessel, and this vessel will take care of the blood supply to it. Then a further modification came, which is the free flaps. What's meant by free flaps is that after you expose this vessel that supplies a certain area of skin or muscle that you just cut it with its vein, the vena comitans that are usually with every vessel, or a named vein if you have a big vein in this area. Then you take it away to a distant site. This is the biggest advantage of a free flap, that you can take, let's say, a flap, a latissimus dorsi muscle flap from the back, and then you put it in the scalp, or you can use it to cover an exposed heel. What you do is you do another dissection. Of course, this needs much more expertise and it's much more time consuming, needs special instruments, microsurgical instruments, that you pick up a vessel in that area, in the area around the area where you want to put your flap or you want to do your coverage. You expose this area and you do an end-to-side, you anastomose the donor vessel that you took out from the distant area into the recipient area vessels through arterial and venous anastomosis. And you can even find a nearby nerve and tuck it into the nerve so that you can make it a sensate flap. This has the biggest advantage that you can guarantee the vascularity. You can take vessels, you can take up an area of skin from a very distant site, like I said, from the back into the heel or into the scalp. Of course, the indications for this is that when you don't find nearby structures or nearby donor skin in the area that's healthy enough to cover the problem that you have, needs special expertise, but the results are very rewarding, of course. And in some way, you have the luxury of taking out muscles or vessels or areas of skin that can be easily covered in a conspicuous area on a named blood vessel, so that when you take it, the morbidity is much less than if you do a pedicle or random pattern flap. Before we leave, we have to say the composite flap is that when you I said it in passing, but I have to say it again now. It's if you take more than one structure, let's say you took skin and fascia, this is a simple flap. If you take muscles with it, if you take underlying cartilage, if you take a piece of a bone for reconstruction, let's say for a mandible that's been broken or been damaged or that infection set into it, then it becomes a composite flap. Composite means that you have more than one structure in your flap. It's more complex. Yes, it's more complex. Viability, of course, it's more difficult, but you're relying on a known vessel that you've been taking with you, be it axial or being free. You still have a known blood vessel with a proper anastomosis done, guaranteeing the vascularity in the area. So it's supposed to be helpful if you have a problem with osteomyelitic bone from exposure after an extensive burn, or in vital structures in the face and ear reconstruction, whatever, you need a composite flap. Thank you very much for listening. And if anybody wants to ask any questions, please be my guest.
Doctor,
Yes.
biobrains, do they have a high risk of infection due to the fact that they're synthetic? Do they act like a foreign body?
You always your first priority is coverage Of course, all these patients are under strong and heavy antibiotic cover. Chance of infection, of course, is always there with any kind of burn, be it if you put a biological dressing or you put a synthetic material. Of course, with the synthetic materials, chances of infection are higher. If you apply amniotic fluid, chances of infection are higher. But your primary target is, as we said, maintaining a proper coverage so that you don't lose fluids from this exposed surface.
Okay, thank you.
Yeah, pleasure. Anything else? Comfortable with
Doctor,
everything? Yes.
when do we choose the occlusive method of management or the exposure method?
I'd say exactly. Some areas in the body, you're better off with the exposure, like the face or the extremities, the hands. Um, Other areas, if it's a superficial burn, it's no problem if you go with it's okay with the exposure method. But the more extensive areas or coverage of the torso, chest, upper arms, thighs, you're better off with the occlusive dressing, especially if the patient is in an environment where you cannot guarantee his behavior with the exposure method. Because with the exposure method, the patient has to be sitting in an area, either in a burn center in his own cubicle, or if he's going to do it at home, at least he's be staying alone. He has to avoid rubbing this whatever ointment that you're putting of it by his hands, by whatever clothes he's going to wear on it. So the verdict is your patient, how he behaves, the degree of burn, and uh, the facility itself. If he's in a proper area where he can understand how to do the proper coverage of the wound area and taking care that it does not get either washed out or damaged by any means, then the exposure method is okay. If this is not applicable, then the occlusive dressing is the best way to go.
Okay, thanks, doctor.
Okay. Anything else? Any questions? Okay, so I wish you all best of luck, and I hope that if you meet any patient in the ER when you're starting your house officer, your internship, please try to memorize this and try to be as helpful as you can, because it's the initial management that makes all the difference. Thanks again, and wish you all the best. Thank you.
Thanks a lot, doctor.
Thank you.